Well, welcome. We're going to get started now. And this is a presentation on EMDR therapy and basic training in EMDR therapy. And my name is Kara Nassardi, and I'm the Director of Training at the EMDR Education and Training Center. I'm also a certified EMDR therapist, an EMDR approved consultant, and an EMDRIA approved trainer. So I run a lot of our basic trainings with the help of some wonderful staff members. And today, what we're going to be looking at are three things. Two things with some opportunities to ask questions, really: an overview of EMDR therapy, and then an overview of EMDR basic training. And then at the end, if you have any questions, I'll hang out and I'm happy to answer those. We're going to give a lot more weight to an overview of EMDR therapy and why we're doing this webinar and recording is, investing in time, energy, and money into a basic training in EMDR therapy is no small feat. So we thought it would be a great idea to give folks a little bit more information about what they're getting into and how this might be useful in their work. So let's get started. What we're going to do first is just have some general concepts about EMDR therapy and then dive in a little deeper. So one of the questions that people often ask is, how is EMDR therapy different from other therapies? And as a general statement, and again, the rest of the day or this hour, we're going to be diving in a little deeper, but EMDR is designed to resolve unprocessed, traumatic, or distressing memories in the brain. And so we're really viewing trauma or unprocessed adverse experiences as a malfunction in the brain, as a brain injury, if you will. And EMDR therapy, one of the ways that it also distinguishes itself from other treatment modalities is it doesn't require a lot of talking in detail about the distressing issue or event. And it also doesn't require clients to complete homework between sessions. What we do in EMDR therapy, rather than focusing on changing emotions, thoughts, or behaviors from the distressing incident, we allow the brain, through unique situations that we'll cover today, we allow the brain to resume its natural healing process after we light up a trauma memory. And so for many clients, EMDR therapy is very effective, very efficient, and as such can be completed in fewer sessions than, say, traditional talk therapy can be. By way of overview, just to give you a visual, EMDR therapy started as a treatment modality for PTSD, which we have up here in that top left corner, but really over the course of the last 30 plus years has expanded. And so EMDR research and applications covers many more things. This is not an exhaustive list, but just to give you an idea of all the ways that EMDR therapy can be used in your clinical practices. And as such, EMDR has been listed as a treatment and an approved treatment for PTSD and other trauma and stress-related disorders by multiple national and international organizations. It's currently practiced worldwide in over 130 countries in multiple languages. And you just see some of the organizations: World Health Organization, the APA, the VA, U.S. Department of Veterans Affairs, SAMHSA, and some International Society for Trauma and Stress Studies, just to name a few. There are quite a few more, but just to kind of give you an idea about where EMDR is in the world, and it is everywhere in the world for good reason. So let's take a deep dive and a look at EMDR therapy. EMDR therapy has a standard 8-phase protocol. These are the 8 phases, and I'll name them and then we'll break them down moving forward here. So history preparation is getting the client ready to begin reprocessing. And then phase 3 is when we begin trauma reprocessing. And that moves through the desensitization, installation, body scan, and closure phases. And then reevaluation is something we're constantly doing to evaluate the work and see if we need to change course and capacity. So let's take a look at this first element, which is history taking. In EMDR history taking, we consider a few different elements in addition to just a person's symptoms and their trauma history. We look at the adaptive information processing model, the client's attachment organization, and the theory of structural dissociation, as well as other elements. And I want to explain these to you here just so you have a kind of a theoretical construct moving forward of what we're doing in EMDR therapy. So let's first take a look at the adaptive information processing model. This was first written about by Francine Shapiro, who originated EMDR therapy back in 1995. And the AIP model posits that we have an intrinsic system to adapt to stressors, right? So this system allows human beings to reorganize responses. We take in information, right? We are meaning-making people, but we reorganize responses to disturbing life events, either big T traumas or little t traumas, from that initial immediate dysfunctional state of disequilibrium and distress to a state of adaptive resolution. That's kind of what our brains and bodies do when things go well. Trauma and or persistent stress, small t events, blocks that system and sometimes forces it to break down when it gets overloaded. And this blockage and overloading can disrupt that information processing, leaving those distressing or traumatic events unresolved and in states to specific form. And really, when those unresolved events are left in state-specific form, in EMDR, we talk about them as being trapped in trauma time, they leave them available to being triggered by anything that the person experiences, either internally or externally out in the world, because they're very much active. They haven't been resolved adaptively. And EMDR procedures, reprocessing procedures, as well as bilateral stimulations, help restore balance to the AIP system. And we'll look at that moving forward in the next hour. And what we do is we light up a memory and allow our body's and brain's own intrinsic healing system to move toward adaptive resolution, resulting in the resumption of healing of that normal information processing until a memory is no longer activated and activating a person in their daily life. So that's just a brief overview of the adaptive information processing system. I will say when we are teaching a basic training, and basic trainings are quite extensive, we go into great detail about that. But I just wanted to give you an understanding of what that looks like so that you understand the theoretical model of EMDR therapy. So the second thing that we're looking at in history taking is a client's attachment organization, right? And we all know as therapists that attachment experiences are the earliest and most influential experiences in establishing those foundational patterns of responses that we would then use to draw on later experiences. So the patterns of attachment shaped by those early caregiver experiences, and this generally gets formed for individuals somewhere in the order of 18 to 24 months. Those patterns are set. Those patterns of attachment influence later adaptive, healthy, and maladaptive, unhealthy coping responses. So when things go well under the confines of a nice, secure relationship, those earlier experiences provide opportunities for a person through childhood and into adulthood to have adaptive coping responses, because those early life experiences get encoded as adaptive memory networks that let someone know that they are lovable, that they are good enough, that they are that they have a certain amount of power and control in their life, that they are safe, whatever they happen to be. But those adaptive memory networks serve as resources for resiliency to later stressful events. So that's the good side, right? But when earlier experiences don't provide any or provide very limited opportunities for adaptive coping responses or overwhelm available coping responses, those tend to get encoded as maladaptive memory networks. And so people learn the opposite, right? That they are unlovable, unsafe, have no control, or whatever it happens to be. So attachment organization is really foundational. Even when we have an adult come into therapy looking at a recent traumatic event, we still want to understand their attachment organization, because that will have more than likely formed the foundation to how that adult client responded to a recent traumatic incident. And I'll just give you an example here, kind of a basic schematic example of what attachment organization and adult coping might look like at the very simplest of terms. So if we have a securely attached kiddo, and this kid, this son, is bullied by a boy at school, this isolated boy at school, and this son shoves the bullying boy back, and the boy falls and gets hurt. And the school finds out and calls the family. And so that evening, the father explains to his son, under the confines of a secure attachment relationship, explains to his son about isolation, gives him encouraging words. The son goes back to school, apologizes, speaks to the boy, and a friendship follows. And this adult son, later on in life, when he himself is an adult, is able to take that attachment relationship and all those subsequent experiences and move into the world safely. This person might have good social skills and strong peer support because they don't have to fear relationship or themselves in relationship. So that's the good, right? If we kind of look at the bad or the ugly, if we look at an example of disorganized attachment, that same experience happens, right? A son is bullied by an isolated boy. He shoves back, the boy falls and gets hurt. This child's father learns about it and threatens his son. I'll show you. And he beats his son into a moment of terrified submission. This isn't a single occurrence. This has happened within the confines of that disorganized and unhealthy attachment relationship. And later in life, this adult son has social anxiety, say perhaps, and isolates because what he learned growing up was that he was not safe and that relationships weren't safe. So this is just kind of on a very, very basic level, kind of showing why attachment organization is so important when we're looking at our clients' symptoms and understanding how they have responded to their traumatic incidents. The third element that we consider quite extensively in EMDR therapy during the history taking, so we're still on phase 1 of EMDR therapy, is the theory of structural dissociation of the personality. And so we look at primary structural dissociation, and this is usually clients who present with acute stress disorder or simple forms of PTSD. And then it kind of moves up in terms of levels of dissociation. So primary is at the basic level. Secondary structural dissociation are generally clients with complex PTSD, which is also known as DESNOS, disorders of extreme stress, not otherwise specified. Perhaps this person comes with borderline or DDNOS. And then the third rung is tertiary structural dissociation, and those are our full DID clients. And so if mental models are useful, I find these quite useful to understand this theory. So with primary structural dissociation, you have your one client who comes to see you, and this person has action systems for functioning in daily life, survival of the species, but they have one emotional part of the personality. They have an EP that was formed in the context of trauma that is responsible for defensive action systems. So they may have a part when it gets triggered, explodes, right? They just kind of lose all calm and cool, and they explode in anger. But they just have one kind of maladaptive coping response. It's a more simple structure, internal structure. And then we have secondary structural dissociation, still one client, one apparently normal part of the personality, but this individual has probably suffered more trauma throughout different ages and stages of their life. So they have multiple EPs. This model shows 3. There's nothing magical about 3. It's just the model that I chose to use for this demonstration. But a person could have, with secondary structural, they generally will have several emotional parts of the personality that generally were developed at different ages and developmental stages in their life in response to different traumas and experiences that were going on. And so when they get triggered, they feel very different, right? They may have a part that feels very young and folds, and another part that is a little bit older and perhaps speaks up and fights back. And then finally, we have tertiary structural dissociation, and this is the splitting of the personality. So we don't just have one apparently normal part, more than one with multiple emotional parts of the personality. And again, you can have multiple of these as well, but for model purposes, I've just given us 2. But the takeaway here is it's important to understand, especially when we are trauma therapists, we need to understand what our clients' ecosystems are, right? What, as a consequence of trauma, what emotional parts of the personality were formed, ones that they may be aware of, and others that they may not, because we want to be able to, in this beginning stage of the work, learn about those and prepare kind of collaborative communication and work with those parts of the personality prior to beginning EMDR reprocessing of trauma. So attachment really does matter in this process. So phase one history taking, like we said, involves understanding the AIP model, our body's intrinsic way of taking in information, dealing with stressors, and if all goes well, putting them away. If not, storing them in maladaptive memory networks. Attachment organization and the theory of structural dissociation. It also involves looking at our clients' symptoms, triggers, and how they relate to their past experiences. And we'll break that down in a few more slides just to give you a sense. But in EMDR therapy, on a basic level, some of the goals and tasks of phase one, history taking, are to establish therapeutic alliance, much like we would with any other client, therapy client. But it's especially necessary with trauma work because we're going to be asking our clients to go to the deep, dark places with us. And we need to have that, not only that they trust us, but that we have good rapport and communication with them. We gather a psychosocial, cultural, and medical history. We assess symptoms and triggers. And from that, we start to develop hypotheses, right, about how the client's symptoms and triggers connect to their past and make sense, right? And then from there, we're identifying memory networks and targets for reprocessing, which we'll talk about moving forward. And we're developing a treatment plan. So we're beginning to understand our clients' symptoms and triggers as they relate to the past. We're organizing their past trauma memories and developing a treatment plan of not only how are we going to reprocess their trauma memories, but perhaps what is the preparation phase work, stabilization, grounding, and presentification work that needs to happen prior to reprocessing trauma memories, because we definitely want to err on the side of keeping our clients safe. So case conceptualization was one of the things that is one of the things that we talk about a lot in history taking, is how do we understand our clients, right? It's thinking beyond their immediate symptoms and looking at maladaptive attitudes, their thoughts, their behaviors, any defenses that they have that they're aware of or may not be aware of, and the ways that they respond, right? Not just behaviorally, but emotionally. And we kind of take all of that into consideration, as well as attachment organization and any dissociative processes. And we begin to form a mental model, right? Grounded in this AIP model that says, okay, we've taken in information to make sense of ourselves in the world, for better or for worse, right? Adaptively or maladaptively. So case conceptualization in EMDR therapy may include a DSM diagnosis, but it definitely does not depend on it uniquely. What we're looking at is a functional analysis of our clients' symptoms, meaning their current symptoms, what brings them to therapy, their triggers, their current triggers, the things that trigger their symptoms in real time, either externally or internally. And we're looking at their trauma history, past adverse, either big T or small t traumatic experiences that cause these symptoms and triggers in the first place. So we're really beginning to organize and form a mental model, a hypothesis about the origins of these symptoms and triggers based on what we're learning about their trauma history. And this mental model is it's a hypothesis about the underlying functional structure of the client's adaptive memory networks, what's working and goes well, and maladaptive memory networks. And so let's just explain briefly what a memory network is in EMDR terms, and you may be familiar with this from other modalities. So a memory network is an associated system of information. So it's a collection of related memories and elements, experiences, thoughts, beliefs, images, emotions, sensations, and behaviors. And some of those memory networks are adaptive. They contain memories and experiences that served the client. And I like to use the metaphor of a file cabinet here. And so we have one human being who has an adaptive memory network here that is, I'm a survivor. And they have a secondary one here that's, I'm responsible and reliable in an adaptive, healthy way. And if we were to pull out this bottom drawer, we would see a list of, I think about a list of files or a collection of files from the very first experience they had up until the most recent experience that the client had that supported this belief and its associated images, thoughts, behaviors, and sensations that helps that client truly feel that they are responsible and reliable. And so that would be an adaptive memory network. Other memory networks are maladaptive. They contain memories and elements that don't serve the client. And so this file cabinet client has a memory network that is entitled, I'm not good enough. And if we were to open the drawer, all the way back, we would find the very first experience, probably in early childhood, where this individual learned, either through something that happened or didn't happen, that they were not good enough, not deserving of love. And there would be a series of files in there, meaning a series of experiences that led them to this belief system and a memory network that they weren't good enough. And so these are the things that we're targeting in EMDR therapy are the maladaptive memory networks, those individual experiences that populated the drawer and formed the system of beliefs, right? And like I said, with each subsequent experience, these memory networks are expanded and the elements are intensified, right? I often think of like a Harry Potter file cabinet, right? It's not just as big as you think it is. It can just keep extending for some of our poor clients who have had extensive trauma histories. And when we're working on these memory networks in EMDR therapy, we're generally working on one memory network at a time. So we organize trauma memories based on the memory network. And within that memory network, we work a three-pronged protocol. And what the three-pronged protocol says, it's essentially the chronological way in which we reprocess trauma memories. We begin in the past and we reprocess all the past experiences in the not good enough memory network. And then we move on and reprocess present triggers and then any future experiences that the client has anticipatory anxiety about. And we do that using EMDR standard reprocessing. And I'll discuss that today as well. And so just to give you an example of what that might look like if we go back to the kid who was bullied at school and pushed the boy over. So if we were using his in very simple terms, it would probably be a longer list, but some of his past memories might include the first time when his father spanked him at age 3, maybe a worse incident when he was beaten up by his dad after the bullying incident at age 12, and then a recent experience where he panicked at a holiday party. Right? And then after we did all of the memories that were still disturbing in the past, we'd move on to present triggers, having to speak to boss, family gatherings, or when a neighbor says hello. And then if there was anticipatory anxiety about future events, we can do EMDR reprocessing on future experiences that this client would have potentially anxiety about. So that's a little bit of information about the history-taking phase. Now we're going to move on to the second phase of EMDR therapy, which is the preparation phase. And some of the goals and the tasks here are to explain and orient the client to EMDR therapy. We offer a lot of metaphors and models to do so. We introduce bilateral stimulation. We introduce and practice any self-regulation tools that the client needs, as well as any grounding and presentification tools for more dissociative clients. And we introduce the log and the EMDR stop signal. So some of the metaphors that we use in EMDR therapy is, trauma is like this ball that you're carrying around with this chain shackled to. And what we're doing and maybe you have multiple chains that you've got shackled and you're dragging through life and making life really difficult. And so with EMDR therapy, what we're doing is with each reprocessing memory that we clear, we kind of release the ball, right? Or I like this image too, like this guy has a lot of trauma, right? I think it works because of the whole phrase baggage that we use in colloquial English, right? But like this guy has a whole history of trauma experiences in this maladaptive memory network that, say, for example, has taught him that he's not safe. And so with EMDR therapy, we're going to organize this and begin to work on it. Other metaphors are like, this is a trauma history. We organize all the threads and then we reprocess them one at a time. Or we can use the metaphor of a messy house, right? We're going to organize all of the items in the house to the rooms where they belong. Those would be different memory networks. So all the kitchen items we'll put in the kitchen, all the bathroom items in the bathroom, and the bedroom items in the bedroom. And those may be three separate memory networks: not safe, not lovable, inappropriately responsible. And then we'll work on each of those rooms individually until they're cleared. So metaphors are often helpful for clients to understand this process. We also use a metaphor in EMDR therapy that's that of a train. And really, the train metaphor is to help clients understand that when they are reprocessing a trauma memory, it's a very passive process for them. They don't have to work so hard. We use the analogy of being a passenger on a train. And when they're watching the eye movement or doing the taps or listening to the tones, they just notice whatever happens, just like you would as a passenger on the train looking out the window. They don't have to work so hard or try so hard. They can trust that their own system, their brain, will take them where they need to go, and that we're there to help them in that process. So we use quite a few metaphors in EMDR therapy. We also, in the preparation phase, introduce eye movements or other alternate forms of BLS, bilateral stimulation. And so this is an image of a light bar that you could use, or some audio that has alternating tones, and then these little orbs fit in the palm of your hand and they're little buzzies. And so forms of BLS are alternating eye movements, alternating buzzies, and then alternating audio. We also can use manual, where people can just cross their arms and tap if you want to go low tech in that way. And there's some theories behind the use of bilateral stimulation. There's a REM analog hypothesis, and this basically says that the bilateral activation of moving your eyes left and right shifts the brain into that processing mode that's similar to REM, where we know that individuals are moving their eyes back and forth, which leads to kind of restarting the process of integrating traumatic memories into the network and allowing them to get worked on again. So this is the activates REM hypothesis. There's also an intrahemispheric hypothesis that because we're asking people to cross the midline of their body and their brain, essentially, by looking left and right, that enhanced hemispheric activity, because we're firing left and right, leads to increased memory strength, vividness, retrieval, and resolution. So that's another integrates neural networks across multiple systems hypothesis. I believe it's a combination probably of both. But again, these are hypotheses that are rather hard to test cognitively. But some of the things that we do know about bilateral is, and this is from many research studies, as well as just anecdotally in our clinical practices, when we're reprocessing with clients, they noticed a decrease in vividness, emotionality, and disturbance related to a memory. They often shift from sympathetic to parasympathetic nervous system. They definitely have enhanced memory retrieval and processing, increased accuracy of memory-related details, induced cognitive and semantic flexibility. They allow for more insight. They can see more things, understand things from different perspectives, and increase metacognitive awareness and executive control. So bilateral is definitely an important element of the work that we do when we're reprocessing. And so we teach bilateral in the preparation phase. Another reason for bilateral is it allows for dual attention, because when we're asking someone to process a trauma memory, we've lit up the trauma memory. But we're also asking them at the same time to be, so they're focusing on the trauma memory, but we're also asking them at the same time to stay present in the room with us. And we do that by asking them to pay attention to the ball moving back and forth, the light, or the taps, or the tones, right? And also we stop the BLS, the eye movements or what have you, at intervals, usually at like 45-second intervals. And we check in with the client and ask them what they notice, which also keeps them anchored in the present. And why we do that is because we want to help the client maintain dual attention. To use a Shapiro phrase, we want the client, when working on a trauma memory, to have one foot in the past and one foot in the present, because we want them to attend not just to the maladaptive memory network, But I don't want them to get just lost in the past, because that's where the maladaptive memory network lives. That's where all their bad thoughts live. I want them to also maintain dual attention to the present, because with present orientation, a client has access to the other adaptive ways of knowing, right? So they may look at their trauma memory and think, I'm a piece of trash because I was abused as a child. But if you were to ask them when they're not looking at their trauma memory, what if this happened to your child? Would you think they're a piece of trash? They would say, absolutely not. No child deserves to be abused, right? So that's why dual attention is a really important part of this work, because it allows for the AIP system to be in balance. It allows for maladaptive to get lit up, but to also make contact with the client's own adaptive ways of knowing. So this is why we teach and use bilateral stimulation in EMDR therapy. Another task of phase 2 preparation is teaching self-regulation and presentification skills and tools, depending on what the client needs, right? And so this is where EMDR therapy is very multimodal. We have things that are specific just to EMDR, but we also draw on other treatment modalities, both from therapy practices and other mindfulness and meditation practices. So square breathing is one. We use a container exercise to help contain, it's a guided imagery to help folks contain disturbing experiences. We teach a calm place, which is a guided imagery that also involves bilateral stimulation to help a person access a calm, imagined place and experience calm in their body. We have a light stream, which is a guided meditation that allows for imagining a light stream to come down and help kind of resolve physical disturbance in the body. We have a remote control that we teach for a client to kind of have a semblance of, or a sense of control of internal or external experiences. We use a back of the head scale to help the client learn to become aware of and to measure levels of dissociation. We teach things such as simple as a beanbag toss for grounding and presentification, or 5, 4, 3, 2, 1 that you may be familiar with. It's not an EMDR specific practice, but this is just to name a few of the things that we might teach a client in the preparation phase, depending on what they're needing, to be able to help them become a little more stabilized and ready to access their trauma memories. We also teach the importance of a log during this process, because when we start reprocessing, we really are lighting up a lot of memory networks. And so clients will have more vivid dreams or randomly other memories that they perhaps had forgotten, or insights will come up. And so we don't want those to be lost. So we do encourage clients in whatever form is possible to jot things down. It can be a formal document or a booklet. I just have my clients do whatever works for them. Notes on a smartphone, a journal, a notebook. I have some clients who come with a whole mess of Post-it notes and they said, okay, here's what I noted this week, and they kind of break it down. So that's an important thing that we introduce and teach in the preparation phase. And then we also teach the stop signal. In advance of reprocessing, we teach a stop signal to enhance the client's sense of control prior to and during reprocessing, right? And so it's taught as a nonverbal hand signal. We can use putting your hand up, or like a T for time out, or whatever the client wants, but it's nonverbal to lessen any confusion that might arise between a possible verbalization during reprocessing of a trauma memory, such as stop. If they're saying stop to a perpetrator while working on a trauma memory, I don't want to confuse that and stop the bilateral when they weren't talking to me. So we teach them a nonverbal signal ahead of time and then remind them of that while we're going. I'll just stop and see if anyone has questions they want to put into the chat, or if it's feeling pretty clear so far. And feel free to write questions into the chat as we go, and I'll at intervals, I'll stop and answer them. All right, so we've taken a history, we've organized trauma memories in memory networks, and we've prepared our client, and now we're ready to begin reprocessing a trauma memory. And we reprocess memories one at a time, and we take the very first memory off of a trauma list. So we start at the beginning in the past, And we begin reprocessing a single incident with a phase 3 assessment of the target. And in this moment, we light up all of the aspects of that memory. So it's not just the thought that they have about the memory, but the image that they see, any body sensations that they feel, any emotions that they currently experience, and any beliefs that they hold. So we're really lighting up all the ways in which a memory is held. And this comes from Shapiro. So 4 of these elements represent perception: images, thoughts, sounds, physical sensations, and emotions. And then the 5th element of her model represents a metacognition, which are the beliefs, right? And folks may lean a little more heavily on some of these elements than others, but these are generally the ways in which we store experiences, traumatic or otherwise. The main purposes of the assessment phase are to activate key aspects of the maladaptive memory network, right? So we're asking about what's the image that represents the worst part? What is a negative belief that you hold about yourself? What is a desired positive belief? What emotions do you feel right now when you think about this memory? And where do you feel this memory and the disturbance of it in your body? We also take another measurement in the assessment phase, which actually 2 measurements, baseline measurements. We want to know, how disturbing does this memory feel to the person right now? Not then when it happened, but what's the residual on this one? So we take a baseline unit of disturbance. And we also want to understand, how true does this desired positive belief feel to you right now, right? So when you think about this memory that we haven't even started working on yet, when you think about what you would prefer to believe, how true does that belief feel to you right now when you look at this memory? So these are just some baseline measurements before we start the process of working on the actual memory. And then we go straight into it. So I'll give you an example here of a phase 3 assessment of a target. This is a target memory of Julie, who was racing her bike while her dad drove alongside. They were kind of like playing, jockeying back and forth. They were having fun until she inadvertently crossed a road and was nearly hit by a passing truck. It was kind of a T-bone situation. She was fine. She got to the other side, but her dad panicked. He couldn't see for a while. When the truck went by, he drove across, jumped out of the car, and ran at her. And he actually grabbed her and said, why didn't you stop? He was in that moment of terror and fear. And so this was a trauma memory that she'd been carrying around with her whole life. And so we ask, what image represents the worst part of this incident? So what we're doing here is we're lighting up this trauma memory to begin reprocessing it. And so what image represents the worst part of this incident? And she says, his frightened face. And what words go best with that image of his frightened face that express your negative belief about yourself now? I'm responsible. And when you think about that image, what would you like to believe about yourself now? I'm a good person. And when you think about that image, how true do those words, and actually it should read, I'm a good person, feel to you now on a scale of 1 to 7, where 1 means they feel completely false and 7 means they feel completely true. So we're gauging, how true does that belief, I'm a good person, feel to you right now on a 1 to 7 scale? She says it's about a 3 or a 4. And then we say, okay, well, when you focus on the image of your dad's face and think of those words, I'm responsible, what emotions do you feel now? I feel anxiety and shame, lots of shame. And on a scale of 0 to 10, here's that second baseline measurement, where 0 represents neutral and 10 represents the highest level of disturbance imaginable. How disturbing does the incident feel to you now? And she says right now it feels like an 8. So then the final question is, and where do you feel it in your body, that disturbance, right? She says, I feel it in my stomach and my throat. And from here, we've lit up a memory and we go straight into EMDR reprocessing. I'll have you note one thing, that this would run in this order and there wouldn't be really any talking in between. In this stage, we avoid having any, extraneous conversation that's unnecessary with the client, because our job right now isn't to talk about this. Our job right now is to light up a memory so the client can begin reprocessing. And largely, I'm going to stay out of the way so that their own intrinsic processes can take place. I'll only jump in if they need help. So on the heels of phase 3, we move into phase 4, desensitization. And the goal of the desensitization phase is to allow for that spontaneous system of emotional response reprocessing, information processing to resume what was previously stuck, right? Kind of in trauma time, maladaptively, we've lit up and we're going to now allow for it to resume our body's own natural reprocessing. And what it allows for is that synthesis. Remember a few slides ago when we talked about dual attention? It allows for that synthesis between maladaptive of the memory and adaptive memory networks, because we're lighting up the memory, but we're also asking them to stay present with the bilateral. The desensitization phase involves offering those bilateral sets, usually of about 30 passes. It takes about 45 seconds, designed to really enhance information processing. Before each set of bilateral eye movements, taps, or tones, the client is asked to simply notice that. Whatever the last thing they said, we just say, notice that and follow, and focus further on the memory. And then after each set, there's a brief check-in. I generally say, take a breath and let it go. And then I ask, what do you notice now? It's a very big, wide open question. They can answer any way they want. I just want to listen to make sure they're still on the target memory. They haven't wandered off to other forests, right? They're still on the target memory and they don't need any assistance. They're not stuck. They're still moving along their train journey, if you will. And we keep going through sets of BLS, occasionally taking a peek back at the target as a whole and checking that disturbance level of 0 to 10 again. But we keep doing this until the target memory has reached an adaptive resolution. And what that means is it's no longer disturbing. That disturbance level went from whatever high number it was all the way down to 0, neutral, no longer disturbing. And once that's done, and hopefully there's still time in the session, but if not, we can continue in a subsequent session, we begin the installation phase. And the goal of the installation phase is to extend the reprocessing and really assure generalization effects. And one of the ways we do this is integrate that positive belief, a new positive perspective, into the target memory. It's a really great part of EMDR reprocessing, because if we think about it, now, what was normally a very disturbing trauma memory, after phase 4, it's no longer disturbing to the client. But we're going to go even a step further. And now let's take this no longer disturbing memory and install into it a positive belief, a realistic, generalizable, adaptive belief that you get to hold about yourself when you think about this memory. And it's very, very powerful. And it tends to have a generalization effect to other aspects of the client's life. So to begin the installation phase, we check to see if they've got a better PC perhaps than the one they started with in phase 3, because they were just guessing right at a PC. So now that they've gone through the process of desensitization, we check in. So when you focus on the memory as it appears to you now, do the words, I am worthy, or whatever their initial PC was, positive cognition, do those words still fit, or is there a different positive belief that's more suitable now? And so let's say the client says, yeah, I'm worthy still fits. That's a great one. And so now we check the VOC. That was, how true does that belief feel to you right now? So I say, all right, well, when you think about this memory and those words, I'm worthy, on a scale of 1 to 7, where 1 is completely false and 7 is completely true, how true do those words feel to you right now? It's definitely a felt sense. It's not a cognition, it's a felt sense. And the client's going to give me a number of 1 to 7. And then we resume reprocessing, but now with an overt inclusion of the positive cognition. So before every set of BLS, I will say, focus on the memory and those words, I am worthy, or whatever their positive belief was, and follow. And so we do sets of BLS. Before each set of BLS in this phase, we give that prompt, focus on the memory as it appears to you now in those words, I am worthy, and follow. And after each set of BLS, we stop the light or the tapping or the tones. We say, take a breath and let it go, and ask what they're noticing. And then we check that VOC again. And we keep going through this process until the clients can hold that positive belief as totally true, until it gets to a rank rating of 7, that it feels completely true when they look at that past memory. After the positive belief when looking at the memory feels completely true, we check our work with one final step, which is the body scan. And the purpose of the body scan is to confirm that there is no residual material left unaddressed in the selected target memory, right? Sometimes trauma will hide out in the body. And also to extend any gains that they have made in the desensitization and installation phases, especially if it involves a new positive physical sensation. So to begin the body scan, we say to the client, close your eyes and hold in mind the original experience as it appears to you now. And those words, positive belief, right? I am worthy. Then bring your attention to all the different areas of your body, starting with your head and continuing down to your feet. And let me know if at any place you feel any tension, tightness, or unusual sensation, or if everything's clear. And then we sit quietly and we wait. They're just sitting there, they're doing a body scan. And one of two things generally happens. There's either negative sensations that come up or positive sensations that come up. And we use BLS to treat both of those. So if the client reports any negative sensations, they're like, yeah, I feel this in my back, upper back. Then we offer further sets of BLS until those body sensations are cleared, until they become neutral or positive. And so we just give the prompt to focus on the memory and the positive belief, I am worthy. Just notice those feelings in your body and follow. And we do more bilateral BLS. And the same is true if the client is like, I feel amazing. I feel like a weight has been lifted off of my shoulder. We do the same thing to enhance positive sensations until they kind of tap out and are no longer positive anymore. Or they're still positive, but they're not enhancing, right? And so same prompt, focus on the memory, positive words, and the body sensations in BLS. And we just allow that to expand for the client. And then the final phase of reprocessing is phase 7, which is the closure phase. And the purpose of the closure phase is to provide a structured sense of completion to each EMDR reprocessing session. So we just don't end and kick them out. For clients that we didn't get through the whole memory yet, because some memories take a few sessions, we want to ensure that they are stable before they leave the room, right? They're grounded, they're feeling in their body, they're okay. So we might go through some grounding or affect, regulation or stabilization practices. And this is the opportunity where, as an EMDR therapist, I tend to talk more, right? Because when they're reprocessing, I'm largely just saying, notice that and follow, notice that and follow. I want to stay out of the way and let them work on their memory without me interfering too much. But this is where both client and clinician can share observations or insights that they had. And we also remind the client, right, that they should observe what they're noticing during the week, document anything that comes up in their log, right? And just follow, because a lot changes from one session to the next because these things are still running in the background, right? And when they come back in the next session, this is where we have phase 8, which is reevaluation. And this is the 8th and final phase of EMDR therapy. Reevaluation takes place on 2 levels, on the macro and the micro. On macro, when we're checking in with the client, we're just considering, like, how were you? How's the week? How are your symptoms? To know, are we on the right track, or do we need to make adjustments to our treatment plan? And then on the micro, we're reevaluating the impact of the previous reprocessing session, right? And reevaluation is a continuing aspect of the EMDR approach. So I hope you're kind of getting the sense that this is even though we're very quiet during reprocessing, history taking, preparation, and reevaluation is a fairly directive process, right? To help take a trauma history, organize targets, get them prepared, and begin reprocessing. And so reevaluation is something that we begin doing in phases 1 and 2, history taking and preparation. We're checking in on the impact for the client of disclosing information, how they're perceiving our responses and the relationship, the impact of skills building and any stabilization exercises on their functioning out in the world, on their symptoms and stability as well. So it's something we're constantly doing at the start of our sessions. And then once reprocessing of trauma memories begins, reevaluation is very important because we want to know, like, how was that work last week, right? So if we completed a target, we want to make sure that it's still complete. And then if we didn't complete the target, meaning we didn't get through all of the phases through a clear body scan, then we just say, hey, can we continue? And we resume reprocessing with them. So we want to keep things moving so that we can get through their target lists and resolve the traumatic memories. So I'll just check in and see if anyone has any questions thus far, if it's feeling pretty good. It's definitely an overview, but I hope it gives you kind of a sense of what goes on with EMDR therapy.
So I do have a question. Do you go through all of the phases within one? I know that all of this can't be resolved in one session, but do you get to, parts of it towards the end just to like close that session and leave them on a good note, or do you work through one as time goes on?
Yeah, so phases 1 and 2, history taking and preparation, are kind of the beginning phases of treatment, right? But then I think what you're asking is once you start working on a single trauma memory, correct?
Yes.
Yeah, okay. So say we're working on that trauma memory with the client Julie with the bicycle, right? Where she was racing her dad on the bike. We'll do and when we're going to reprocess, I try and jump in as near to the beginning of a 50-minute session as possible, so we have as much time to get as far as possible with a trauma memory. So we'll do phase 3, we'll light up the memory, we'll start phase 4, desensitization. I won't ever skip ahead to installation and body scan if I haven't finished desensitization. It's okay to stop wherever you have to stop naturally because the session is about to come to a close, but you don't go into installation until you got the memory totally resolved from disturbance in phase 4. So you have to finish phase 4 desensitization before you begin phase 5 installation, and you have to finish the installation before you do the body scan. That being said, so never skip ahead. But say, for example, I was working with Julie on that bicycle memory. We did phase 3, we lit it up. She did a lot of great work in the desensitization phase, but I realized, okay, we've only got about 5-6 minutes left in our session, and we're still in the desensitization phase. I'll probably close the reprocessing right there. After a set of BLS, I'll hear what she says, and I'll say, okay, we're going to put a pin in this for today. We're almost out of time. I'll acknowledge her work. You've done amazing work. How are you feeling? And I'll do closure. So I can stop in phase 4 desensitization and skip to the closure phase because I want to allow for a good 5 minutes to give her whatever she needs. Do some grounding, put the memory in the container, do some breathing, and then chat a little bit about what happened. Right? Does that make sense?
Yes, it does. That's helpful. Thank you.
Okay. Yeah. We never want to skip ahead because if you think about it, if a memory is still disturbing, they're still in the maladaptive mud. How am I going to install a positive cognition? They're going to look at me like, are you kidding? I still feel like I'm trash. How are you want me to think that I'm good? Right. So it really is a natural progression of no longer disturbing and then moving toward installing the positive. Any other questions before we move on? I want to share, let's see, probably about 8 slides here about the basic training process. So this is the basic training that we offer at our organization. And I just wanted to show you, I'll give you an overview, but then break down the different days of our training just to kind of give you an understanding of what you learn in a basic training with us. So our basic training has one of the most comprehensive curriculums. We have an 8-day training, which is one of the bigger ones out there, but it's a lot of information and it's really important work. And so we make sure that we train our clinicians quite well in this process. So our comprehensive curriculum integrates all of the required elements. And when I say required elements, EMDRIA, EMDR-IA, which stands for EMDR International Association, is the governing body in the United States and most of North America for EMDR therapy. And so to get basic training, you want to pick an EMDRIA approved basic training. Ours is, many others are as well. And they have required elements that you have to complete in order to be basic trained. Our training encompasses all of those into one program, essentially. So you get 25 hours of instruction, over 21 hours of dyadic practicum, and then 10 hours of small group consultation. And so when you finish our basic training, you are considered a trained EMDR therapist. You can call yourself an EMDR therapist, market yourself as such, and and move forward. And you will have already begun integrating EMDR in your clinical practice because we do consultation along the way. And so how we break that down is we have 8 full days of training, and they're full days. They're 8:30 a.m. till 5:30 p.m. if you're on the Pacific Coast. All our trainings are remote on Zoom, so you can adjust times if you're not in California or on the West Coast. But we deliver these 8 days in 2-day modules once a month for 4 months. And we have midweek and weekend schedules. So for example, I actually just taught a 2-day module yesterday, which was the 3rd module on Saturday and Sunday. And so we'll meet again one more month for module number 4. So we break the 8 days down into 2-day modules once a month for 4 months. So we do a midweek, a Tuesday, Wednesday, and then we do a weekend, Saturday, Sunday schedule. And we also have discount and installment pricing. If you are a pre-licensed clinician or if you work for a nonprofit full-time, you get discount pricing with us. We have an amazing training team who are experts in their field, and they really work with a variety of diverse populations and settings. So you get a lot of folks. I've got folks on our team who do EMDR with like perinatal work. I've got folks who work in the prison system, folks who work in private practice with kids, folks who work with adults, vets, couples. So we have a wide variety of individuals who are part of our training team that I think enriches the experience. And we also try and keep this as multimodal as possible. So there's a lot of variety of learning opportunities within our training. We use slides, transcripts, we have tons of Q&A, small group discussions, large group lectures, lots and lots of video demos. We use graphics, metaphors, practice, and consultation. So we really try and hit this from multiple ways of learning because all of us are such different learners, right? And we are an APA approved sponsor. So our EMDR basic training is approved for 58 continuing education credits. And I'm just going to briefly break down our 8 days, just so you kind of have a sense of what the heck would we do for 8 days in a training. So module 1, we start with a baseline foundations of trauma and dissociation. So this is day 1, essentially. We go into attachment theory and the classification impact on EMDR, so how attachment impacts EMDR therapy. We look at the structural dissociation, and then we teach methods of stabilization. We do a deeper dive into understanding the adaptive information processing model. And then on the very first day, because we teach remote trainings and because you'll be practicing reprocessing with each other in the training, we teach how to deliver EMDR remotely via telehealth. So if you're a remote, like a telehealth therapist, this will be great for your practice. But even if you're not, you'll need it for doing the training. And it's fascinating. I've been doing remote EMDR since the pandemic hit. I gave up my office and never went back, and with my clients, and it's quite powerful. Practicum that day on day 1 involves stabilization exercises. So a lot of different EMDR specific and more general modalities for stabilization. So that's day 1, module 1. Day 2 of module 1, we look at memory networks and dual attention more in a more expanded fashion. We take an overview of the 8 phases of EMDR therapy. And why we do that before we begin teaching them is I'm a huge fan of like kind of preview something, teach it, and then practice it, and then review it. So that because EMDR is really re-envisioning how you're working with clients, and so it really does take a lot of preview, do a deep dive, practice it, and review it. And so we really do a lot of backstitching throughout the training to make sure that folks have a clear understanding, not just theoretical, but practical knowledge of it. So we do this overview. And then we teach phase 1, history taking, case formulation, and treatment planning, where every time we're teaching new elements, we're looking at how to consider, we're offering cultural adaptations, but then also getting people thinking about different ways that you might modify practices, not theory necessarily, but practical application of EMDR therapy to meet the needs of your unique clients. We teach how to assess readiness for reprocessing. We also teach phase 2 preparation. And here's where we begin to show a lot of video demonstration. So we'll show ComPlace and RDI. RDI is a resource practice. These are both both EMDR practices, and RDI is a resource development and installation. That's a wonderful practice that is an ego strengthening activity that involves bilateral stimulation. Practicum exercises are preparation phase exercises this day. We teach the complaints, and then in your dyadic practicums, you practice the complaints as well as that resource development and installation. Because before we ask you to do something with clients, we want you to have practiced it in session. And all of our dyadic practicums have supervisors, that clinical supervisors coming around and helping out to answer questions or to jump in if you need help. So that is day 2, module 2. And then we have homework that we assign where you go and integrate some of the history taking and preparation phase work with at least one client between modules. And so our homework is very well defined. It's not nebulous. It's very clear and concrete. We give you lots of tools and tricks. And you go forth, you go away for a month, integrate this work with your client. We're available if you need help between months. And then you come back for module 2 a month later and begin day 3. In the lecture of day 3, we're going to review what we did last month, history taking. We're going to teach some new techniques for history taking, which is the bridge technique. We're going to further expand on history taking because it is a new way of thinking and working with clients. And so we want to offer as much support as possible. So we talk a little bit more and give a lot more examples of how to create symptom-informed treatment plans and target lists of memories. And then we introduce and do a deep dive into phase 3 assessment of a target. We teach cultural adaptations to that. And then we introduce phases 4, 5, 6, and 7. And video demonstrations during day 3 are showing clinical work on phase 3. This is the first day because we've done module 1. We sent you off with homework. You come back. Our day actually doesn't begin with lecture. It begins with an hour and a half of small group consultation that's led by an EMDR-approved consultant. Our groups are no more than 10 people. They generally end up being around 8 people each, which is great. And we do those both days on day 3 and 4 for an hour and a half each day. There's afternoon practicum that involves practicing history taking, practicing negative and positive cognitions, and phase 3 assessment practice in both small groups and dyads. And then the next day of the module, day 4, we review the assessment phase that we taught on day 3, and now we do deep dives into phases 4, 5, 6, and 7 of EMDR reprocessing. When we teach each of these, we talk about and suggest cultural adaptations to reprocessing to better meet the needs of clients. And we show video demonstrations of actual reprocessing sessions with clients. Morning consultation happens before lecture as well on day 4. And then afternoon practicum involves, this is the day where you all start reprocessing with one another in dyads with supervisors coming around and helping out. So this is where you would begin reprocessing with your practicum partner. And it's not role play. We help folks design like professional environment appropriate target lists, usually like phobias and different more adult stuff. And you actually do begin reprocessing, and it's quite powerful. Again, I just taught the training this past weekend, and I'm one of the people that also goes around and just observes reprocessing sessions, and there's such beautiful work done. So not only does the person in the role of clinician get to practice being an EMDR therapist with a partner, but the person in the role of client, gets to get some free work done, right? But also gets to experience what it's like to be an EMDR client, because I think it's really important before we should experience, right? So then we send you off with more homework, and you come back a month later for days 5 and 6. Day 5, we review case conceptualization and target sequencing again, adding more fine-tuning elements to it. We review procedures and principles of reprocessing, and we introduce how to do macro and micro level reevaluation. And we spend the afternoon lecture portion introducing how to do EMDR therapy with children and adolescents. Video demonstrations on this day are phase 8 as well as phases 4 through 7. There's one with an adult as a client and a second video demonstration with like an 8-year-old girl. It's kind of fun. Morning consultation happens before lecture on day 5 for 90 minutes. And afternoon practicum involves practicing reevaluation that you just learned that day and doing more reprocessing with your practicum partner. The next day of module 3, day 6, we begin to introduce a special protocol, and this is a protocol for treating recent events that is doing EMDR reprocessing, but in a slightly different way, because oftentimes recent events haven't consolidated for folks into one memory. And so we teach a protocol for how to do that. And then we talk about on day 6, the whole day really is spent on how to know if reprocessing is going well, how to maintain effective reprocessing, and then what to do if things go awry. So how to restore effective reprocessing. And really that's the topic of the entire day 6. And one of the subtopics under there of restoring effective reprocessing is a topic called EMDR interweaves. And those are clinical interventions to help your client if while they're reprocessing a target memory, they get stuck. You can use an interweave to help get them back on track and resuming effective reprocessing. It's a big topic, and so we spend the whole day talking about that, and then other days moving forward. And then video demonstrations are on reprocessing of a current trigger that also involves interweave examples. Day 6 also begins with morning consultation before lecture. And afternoon practicum involves a small group interweave practice, so folks can kind of roll up their sleeves and begin to practice using interweaves. And then dyadic reprocessing of the third target on their trauma list with their partner. And then again, after module 3, we send you off with more homework to continue building this work with your client between our training modules. And then you come back on day 7. And day 7 is where we start to expand. So we've taught the basics of EMDR therapy, and now we begin to introduce different treatment plans for working with specific populations and presentations. Certainly not all of them that I showed you, but we do want to give folks some more specialized expertise on how to do EMDR therapy with certain diagnoses or clients. And so we teach a treatment protocol for working with specific phobias. We teach how to treat panic disorder with and without agoraphobia. So it's a treatment planning is a little bit different. We teach an inverted protocol for complex PTSD for folks who don't meet criteria to begin reprocessing past trauma yet, because their distress and their PTSD is so severe that if we ask them to go back to their earliest childhood memory, we would destabilize them greatly. So there's a protocol for working with more complex presentations. We also teach a protocol called CPOS for highly dissociative clients, which is constant, and CPOS stands for constant installation of present orientation and safety, which I recognize is a huge mouthful. But it's this wonderful protocol for people who, if they were to go in and start reprocessing a trauma memory, we would lose them to dissociation. So it's this way of installing present orientation and just taking slow little looks. We're titrating and increasing their ability to look at past memories before we ever reprocess. So this is really a great day about learning to fine-tune your EMDR practices. We present a protocol and treatment plan for treating depression with EMDR therapy, as well as substance abuse and compulsive behaviors. And we show a video demonstration, part 1, because it's a target memory that took 2 sessions to complete, of a client's worst trauma memory. It was a memory of sexual abuse by her brother. Day 7 begins with morning consultation, just like the other days, and ends with afternoon practicum, where we reevaluate the prior target from the prior module and begin again reprocessing a new target in dyadic practicum. So you see, you get a lot of practice in the afternoon practice sessions. I mean, these sessions are a couple hours long, and we take breaks, obviously, and break it up with discussions, but you get a lot of great time reprocessing with your partners and your cohort members, so that the first time that you reprocess isn't with an actual client. That's really important. And then there's a CPOS practice also if folks choose to do that. And then day 8 happens, and we talk a little bit more about how to complete a treatment plan. We talk about reprocessing future targets. We teach a new way to resource a new self-concept. You know, once you're done doing all of this work with the client, there's a resource protocol for kind of integrating and kind of updating their system of how they get to view themselves and how they get to experience themselves in the world and internally now that they're no longer defined solely by their traumatic history. We talk about and teach ways of working with survivors of incest, abuse, and early neglect. And along those lines, we teach a procedure called Loving Eyes procedure, which is designed to allow for compassion for a former self, because so many of our complex trauma clients look back at their former self who was poorly treated, and they look back at that young kid, right, their young self, without any compassion or care. And so we teach this Loving Eyes procedure that's really helpful in beginning to kind of sow the seeds of compassion. We teach a positive affect tolerance protocol for people who experience a lot of early neglect. They oftentimes didn't receive that secure attachment experience that allowed them to kind of encode and have essentially the neurocircuitry to be able to tolerate positive affect. I consider these people more like ducks, right? So compliments, affection, praise, or just kind of roll off them like water on a duck. They're not sponge-like. They don't take it in, right? And I'm sure you've seen clients like this who they can't take compliments, they deflect or disparage themselves. And they'll tell you things like, I see my children playing at the park. I know I should feel happy, but I feel nothing, right? And so this is a wonderful preparation phase protocol. And then we talk more about the EMDR community and ongoing education after a basic training, kind of next steps. And video demonstrations during day 8 is the second part of what we watched on day 7, the worst target memory. Day 8 offers a little bit more consultation. We do the morning consultation and then we do lecture. And then there's also, we finish out the day with another hour and a half of afternoon consultation that happens not in the small group, but in the large group, which is really nice to end the training with everyone coming together because we've all spent a lot of time together and done a lot of work together in a large group consultation. And before that, we do have afternoon practicum that is more reprocessing. And if folks want to practice the Loving Eyes procedure, they have that opportunity. So that is a breakdown of our quite extensive EMDR basic training. And this is us. We are the EMDR Education and Training Center. Again, my name is Kara Nasardi, and I'm the lead trainer for these trainings. Our next one begins in August of 2024, and you can access it just by going to emdreducationandtrainingcenter.com, or if you want to add in those other credentials, you can do so to get to it. So I will open it up and see if anyone has any additional questions that I can answer about EMDR, about training, or anything that I can answer in that vein. All good?
I just want to say this was extremely helpful. So I am already looking at the
good.
trainings for August. And I'm
Oh,
very
good,
interested.
good. Oh, I'm so glad. We actually have an early registration discount that will go for the next 2 weeks. I think it ends on the 15th of July. So good timing. Yeah, it's a really great training. I really like this, the model that we use. I was actually trained in the same model many years ago, and I think it's really useful. I will do consultation with a lot of folks who didn't get trained by us or in this more comprehensive manner. And we end up having to fill in a lot of gaps, what they didn't get. So I think if you want to do EMDR therapy, it's good to find a more robust training. So hopefully this was helpful. All right. Well, any other comments or questions that I can address for y'all? Well, thank you so much. I appreciate your time and attention. And please do get in touch. My name is Kara Nasardi. And if you go to the EMDR Education and Training Center, there's a contact us button that you can use, and you can reach out to me. I'd be happy to get in touch. All right. Thanks so much, everyone. Have a great day.